Sergey, I think we can start.
Thank you. Thank you so much. Dear colleagues and dear participants, so we are glad to invite you to the next webinar hosted jointly by the EANS Pediatric Section and EANS CSF Task Force. Practically it is a joint event with the International Federation of Neuroendoscopy, because we have the president of the IFNE in our faculty, and to my mind, 2 or 3 members of our faculty are the members of the IFNE. So our event is entitled The 5 Ages of Hydrocephalus. So, and to my mind, it is a very important topic, as many people guess that hydrocephalus may differ in children and adults. But it is necessary to understand that pathophysiology, diagnostics, and treatment has real differences in every period of life. So, and thus we have several speakers who will speak on the definite period of life, speaking about the peculiarities, the differences of the hydrocephalus in these periods. So on our among our panelists, we have 5 speakers, and we have 2 invited experts. Henry Schroeder from Germany, as I told you, he's the president of the IFNE Society, and Mansour Faraji from the United Kingdom. He's the chief of the CSF task force of EANS. So, and it's my pleasure to invite Marianne Juchler from Denmark. He is the vice chair of the pediatric section, and I think that she also wants to say some words in the beginning. Marianne, please.
Thank you, Sergey. As you mentioned, we have 5 excellent speakers, including yourself, actually, to enlighten us on the 5 ages of hydrocephalus. This was originally a masterclass during an online EANS conference last year, and we found that this masterclass was so successful that everybody agreed to broadcast it to a broader public in this way. We welcome Professor Ulrich Tomale from Charité in Berlin to speak about infantile hydrocephalus, Professor Martin Schumann from Tübingen in Germany to speak about pediatric hydrocephalus, Professor Sergei Gorylyshev from Russia to speak about the transition age of hydrocephalus, Professor Lawrence Watkins to speak about adult hydrocephalus, and Professor Uwe Kehler to speak about normal pressure hydrocephalus or hydrocephalus in the old age. You already mentioned our expert panelists, and you and I, Sergey, are the moderators. And being a moderator, just a bit of housekeeping. Questions to be answered by our excellent experts are to be put through the Q&A. Please do not put your questions in the chat, because it will be very difficult to get an overview this way. So questions in the Q&A, please. And I think we can invite, with these words, our first speaker, Professor Uli Tomale, to give his talk.
Thank you very much, Marianne. Thank you very much, Sergey and the EANS for inviting me. It's a pleasure and, of course, an honor to participate in this endeavor. And my talk, as mentioned, is about infant hydrocephalus. Since I'm the first speaker, I would also talk a little bit about classification of hydrocephalus, which is quite complex, especially if you look at the pediatric side, and we have different like pathophysiological mechanisms, which we count at the number of 7. being the pulsatility of arterial blood flow, choroid plexus, and arterioles causing the CSF production, major pathways of communication between the ventricles and the external CSF spaces, minor pathways within the parenchyma, the absorption of CSF, the venous outflow, and the respiration. If we look at communicating hydrocephalus, it's the majority of all these causes, and non-communicating hydrocephalus only projects to the problems in the major pathway communication issues. And then you can go through different kinds of hydrocephalus, which I don't want to go into detail because of time restraints. However, it's important to mention that in the individual patients, it might be different. That, for example, in the aqueductus stenosis, you have only one reason for hydrocephalus, but in this case of a choroid plexus papilloma, you have the overproduction of CSF and the midline shift causing foramen Monro and aqueductus stenosis, and you have already two reasons for hydrocephalus. It becomes more complicated in post-hemorrhagic hydrocephalus, where you have the resorption problem due to protein overload, and then inflammatory responses will cause aqueductus stenosis, and you will have different ones. Or in spina bifida, where the posterior fossa is very small, there will be problems of venous outflow, there will be congenital problems of the parenchyma, and we will have major CSF pathways. And these factors you need to interpret per case individually. In terms of treatment options, it's more rough. We have more simplified measures to treat hydrocephalus. And in infants, taking reservoirs are very important in patients who are under the age, the body weight of 2 kilograms and with high protein levels or high CSF cell counts. For endoscopy alone, it's maybe not the best option to treat non-communicating hydrocephalus, for example, which is the basic indication for endoscopic means in order to open the floor of the third ventricle. As you can see here, you have the aqueductus stenosis, you have a pressure gradient at the membranes of the third ventricle towards the external CSF spaces, and you have a triventricular hydrocephalus, and then you normally do a third ventriculostomy. Is that indicated in infants at all? Yes, it has been investigated by Kulkarni, introducing the ETV success score, which is a very important measure and which basically gives age as the most important factor for success. And we consider 6 months as a age threshold for ETV in patients with pure aqueductus stenosis, for example. This has the rationale based on the infant hydrocephalus study, which was published in 2016 the first time, but subsequently in other cases as well. In basic, patients were included at the age under 2 years, and you can see that ETV has less success compared to shunts. But if you compare patients who are younger than 6 months compared to older than 6 months, these curves start to equalize and in the older infants. So if they are older than 6 months and we have a clear aqueductus stenosis as an only pathological issue, we would consider them. On the other hand, we have to think about neurological development in those children, because with a shunt, the ventricle becomes small, and with the ETV, they remain large. The ETV, the infant hydrocephalus study did not answer any questions towards this. There were only tendencies that shunts are doing a little bit better, but no significant differences. However, the ventricles are actually larger, as well as the head circumference remains larger after ETV. Post-hemorrhagic hydrocephalus, one of the major problems in infant hydrocephalus. It's the primary damage due to bleeding. Then the hydrocephalus comes into place, which cause parenchymal damage as well. And then we have treatment complications caused by the neurosurgeons. In our opinion, it's very important to get rid of the intraventricular blood, and we use endoscopic means with the technique of neuroendoscopic lavage. It's a single intervention in a controlled environment in the operation room in order to irrigate the ventricles and aspirate the clots of blood in order to decrease the burden of those products which cause further damage. Here you can see that the endoscope is able to reach all the supratentorial CSF spaces despite the temporal horn. And in general, you can use up to 3 liters of warmed lactate-free Ringer solution, and the OR time is normally 70 minutes in mean, how we can do it. Our results lead to a reduction of shunt rate from 100% in our historical group compared to 60% in our neuroendoscopic lavage group. And moreover, it was also a reduction of infection rate as well as a reduction of multiloculated hydrocephalus. If we look in the literature, which was also published more recently, there are very stable results also from other groups from Spain, as well as from Italy, from United Kingdom, which showed the same reduction of infection rate and shunt rate accordingly. But over the time, we also get less complication with the shunt, because the shunt is placed in an environment with lower protein levels. And that's why the curves of shunt revisions within the first years equalize with other entities of hydrocephalus, and the revision rates could be reduced compared to our historical cohort. Also, our neurological outcome was here compared to the drift study, and had decent numbers of as well spasticity as well as a neurocognitive outcome measured in Bailey scale, which showed beneficial results. If we compare the neuroendoscopic lavage to more like often used techniques like external ventricular drainage or reservoir or ventricular subgaleal shunts, we showed only in the bicenter study that the infection rate was reduced, the arrested hydrocephalus rate was increased, the mortality was reduced, as well as the operative revision was reduced. But further data is necessary. However, on the basis of this data, it was already recommended to perform neuroendoscopic lavage as a feasible and safe option within the guidelines for treating of post-hemorrhagic hydrocephalus in infancy as a level 3 recommendation. So we need further data to prove these results. And this is our endeavor performed in the trophy registry study, which is still ongoing in recruiting patients in order to compare neuroendoscopic lavage with EVDs, ventricular access devices, and ventricular subgaleal shunts, and get data on revisions as well as safety and neurological outcome for long term. What about shunts? Shunts in our cohorts are in infancy. 75% of our pediatric hydrocephalus patients will receive a shunt during an age lower than 2 years. However, shunts are not maybe the best friends of neurosurgeons. If we look at historical results before the shunt was invented, and we compare them to more modern results, we can see the shunt is maybe one of the most successful treatments in neurosurgery at all. And this needs always to be considered for somebody who doesn't like to put a shunt. Our way to do it, I don't want to go in detail again, but we use a frontal burr hole. We use enough tubing between the reservoir at the burr hole and the valve in order to let the head grow. We use a long insertion of a peritoneal catheter also due to growth of the patient, and the body weight should be above 2 kilograms, and the protein level should be lower than 2 milligrams per liter, 2 grams per liter. What about complications? It's the main state to avoid any kind of complications like infection, obstruction, loculation, malpositioning of any implants, and then to titrate the right amount of drainage through the shunt over a long time, basically a lifelong period for the patients. And this needs to be considered. About infection, the protocol, how to implant the shunt is the most important thing, which should be worked on in any department as the first line thing. we use as for infants under the age of 1 year always Bactiseal catheters. However, if it's too expensive, we has an alternative to put the implants into vancomycin bath of 500 milligrams to 250 milliliter solution in order to reduce infection rates in addition. The BASICS trial already showed that the Bactiseal catheters, which are basically impregnated with antibiotics like clindamycin and rifampicin, showed a significant reduction, not only in pediatrics, but also in adults for shunt implantation. The importance of using antihydrostatic antihydrostatic valves has been investigated in our group quite substantially. This is our publication, which is only for infants, and the survival curves of the shunts and the valves are not as good as for the older children, as you can see here. However, all of those children cope with the fact that they have implanted anti-gravitational devices, so they are not too big, and they are still controlling that over drainage is not an issue over time. And this is very important, for example, for spina bifida patients, because over drainage is the biggest problem in those, especially if the Chiari malformation is there, that the head should grow, and we should have keep enough space for the posterior fossa in order to avoid any kind of surgery for the Chiari in the posterior fossa, and that's could be shown in our data also previously. So we look for different adjustments of the valve according to the patient's pathology, the ventricular size and CSF volume, and the age and activity of the patient over time, and the age and body height. And for even the early follow-up, of course, we look for clinical symptoms, but they are not as easy to interpret in infants. Head growth is the most important parameter in order to adjust the valve over time for more resistancy, and then to use ventricular width measurements in order to avoid split ventricles. What about endoscopy with shunts together? This is an example of a isolated fourth ventricle, which was treated with an interventricular stomy stent. And in infants, it's very important to see that the head is growing, and the catheter can passively retract over time and then needs to be replaced again. So this is a peculiarity of infants, that head growth will decrease the length of the ventricular catheter. For aqueductoplasty, it's very effective, even if we do it in early time, that we can decompress the brainstem and we can reduce the size of the fourth ventricle even after 24 months. And we also can reduce the amount of acute symptoms in those patients if they have isolated fourth ventricle. Even more problematic is the multiloculated hydrocephalus, where we have a complete distortion of anatomy in the ventricular system, and we have multiple cysts. There we need to combine navigated endoscopy in order to fenestrate all those cysts and combine them. And sometimes multiple surgeries are necessary. We would like to avoid those kind of implants with multiple shunt catheters and multiple valves and too many ventricular catheters. Our concept is to have one valve, one peritoneal catheter, and then not more than two ventricular catheters, which are then connected prior to the valve with one Y connector. So this is the aim. Neuroendoscopic lavage can also be applied in ventriculitis. It's very effective in infants in order to keep the brain tissue developing over time. This was a very small neonate which needed to have a neuroendoscopic lavage and ended up with a shunt, but had good development of the brain tissue over time. We could see that the shunt rate is higher than in post-hemorrhagic hydrocephalus. We could see that the neuroendoscopic lavage could reduce protein and cell count significantly, but more importantly, the revision rate and the reinfection rate was significantly reduced in those patients by using this technique. It's more complex that we all know, and this should show this last of my slides, that if we use endoscopic means, there's neuroendoscopic lavage and IVH and IVI. but of course we have other patients as well, and we have like reservoirs and VP shunts sometimes put initially, and the variety of what to place when is very important, and this needs a lot of experience. In general, we can see intraventricular hemorrhage has a 60% shunt rate, intraventricular infection have a 90% shunt rate, and others who have as later had any kind of neuroendoscopic intervention had 100%. In summary, hydrocephalus remains to be a very complex disease, especially in infancy. Most hydrocephalus patients will be diagnosed during this time period, and shunt is a relevant advancement in neurosurgery in general. That's why we should keep it as such and have it in mind as a valuable tool in neurosurgery. Endoscopy has become an essential technique for optimal treatment in pediatric hydrocephalus, and the main challenge is, of course, to avoid complications in those fragile patients. And being aware about the complication of infections, correct implantation, occlusion, long-term overdrainage, which are the major problems. The factors to be better in treatments is, of course, experience, protocol, which need to be implanted in all centers, long-term solutions, and at the end, dedication to do better. And this, at least, is independent of any costs of implants, which we can use, because this can be done by any surgeon. Thank you very much for your attention.
Thank you. Thank you, Ulrich. It is a very important speech. So please, for the participants, would you be so kind to ask your questions not in the chat, but in the special list for the questions and answers? You have the special button on your screen. We have several questions. What would be the diagnostic tool of choice for hydrocephalus in infants?
Yeah, this is something I did not mention. Of course, it's ultrasound as a first step, but we tend to do more and more MRIs in any patient, because especially if we have the indication to perform endoscopy, which is always an option, either to support the shunt or to make it as initial solution, we perform MRIs in patients, especially if the ultrasound finds some like isolated compartments. This is the most important thing. So if the ultrasound finds an isolated compartment, we do an MRI as a second stage of diagnostics. And then, of course, fontanelle stage and head circumference growth is the basic clinical science which need to be investigated.
Mm-hmm. Thank you. Another question, any role of repeated ventricular tapping initially? If so, how long we do it? Yes, it's a popular question usually.
Sorry, I did not understand the question.
You may see the questions on your screen. What any role of repeated ventricular tapping initially? As the first step.
Yeah, so ventricular tapping should, in my opinion, only be done through a reservoir and not through the fontanelle. And through the fontanelle should only be done in emergency cases, if a neurosurgeon is not in place to place a reservoir, because the infection rate is basically too high to always tap through the skin directly in the ventricles. But then the tapping through a reservoir depends on the dynamics of the hydrocephalus. And if it's needed, it needs to be done every day, in my opinion, sometimes even twice a day. And we use like 10 mils per kilogram body weight per tapping in order to make it not too much and not too less. And we always can taper it according to the fontanelle status, which is the like very sensitive measure, not to do too much and not too little.
Mm-hmm. Thank you. So one more question. What is the long-term prognosis of hydrocephalus caused by intraventricular hemorrhage?
In general, maybe IVH has the worst prognosis compared to any other diagnosis or reason for hydrocephalus in infancy. That's the basic rule. And there was a very nice paper from Great Ormond Street about this, I think recently from last year. But in general, we can improve this type of hydrocephalus by like trying to get the blood out as early as possible with as riskless as possible as well. So but we need to know that the outcome compared to other types of hydrocephalus is worse. Yes.
So, and one practical question from me, perhaps. So, Ulrich, what are the CSF features, parameters, which make possible to proceed to the shunting procedure, if necessary, after the intraventricular hemorrhage?
Yeah, so we would like to have a protein.
Count, albumin, and so on.
Yeah, we would like to have a protein level lower than 2 grams per liter. And if it's higher than that, we would do a neuroendoscopic lavage, even if we have done a previous neuroendoscopic lavage. Sometimes then we combine the neuroendoscopic lavage with shunting together in order to get the protein levels down. However, there's no scientific proof for this value. Cell count and lactate as well as glucose should show that there is definitely no infection in the CSF, which would also be a contraindication to put a shunts, definitely. Otherwise, you have to clear the CSF with antibiotics and also with neuroendoscopic lavage as an additional tool.
Okay, so Marianne, we have to decide what to do with the questions. We have a great amount of questions, so I'm not sure that we are able to answer all of them. Otherwise, we shall speak till the morning. So our participants are very active, but we have to proceed to the next report, to my mind. But we shall try to answer the majority of questions, I think. Thank you for the participants. And okay, so let me invite the next speaker. So now we are going to the older age, the hydrocephalus in children. So, and I hope Martin Schumann, the professor from Tübingen, from Germany, will focus not on the neonates, but on the older children. Martin, you are welcome.
Martin, if you could just turn on your microphone, please.
Martin.
Okay, thank you very much. Sorry, the microphone had to go on. Thank you for the invitation to talk on hydrocephalus in children. These are my disclosures, and it's a team effort, of course. It's that what our team has worked on in the last years. There are some disclosures regarding honoraria. And the question is now, I want to answer more specific, because Ulrich Thomale has covered many general principles which also apply to the children age and not only to neonatal age. So the question is, and we did some investigation, at which age actually starts overdrainage if you put in a non-protected shunt? How effective is gravity protection according to the age of the children? And what happens if you cut a distal catheter in the shunt? Because many people still cut the distal catheter if they put it in neonates. And this has downsides, of course, and that is something we want to answer from the hydrodynamic point of view. Another important question, ICP, how can we not monitor that non-invasively? Because ICP is one of the main worrisome things in hydrocephalus treatment. What is the role of papilledema? How can I monitor ventricular size without using CT and MRI? And I think that are the questions I want to cover. Other interesting questions we have to leave for the future. As you know, we have a lot of dynamics along the road, and Ulrich has been showing to you already a little bit about that. So everything grows, the head, the brain, the body, the ventricular size changes in configuration. The ICP dynamics become fundamentally different over the time. We have a very low physiological pressure in the very small newborns and infants, and that increases over time. We have a decrease in compliance because the head becomes stiff, and therefore the pulse amplitude and the pulsatility increases. That changes the dynamics. We have an increasing time in vertical position when the children move up, stand, walk around, spend most of the time in the upright position, which per se lowers the ICP, as we all know that in a standing position, our ICPs are low, around 0 or negative, and we have positional changes which also affect the abdominal pressure. We have the body size dynamics, and so given the different underlying disease pattern, we have an extremely individual course of each patient. And that makes it very difficult to formulate any general principles because each patient needs a personalized treatment, of course. But some principles can be there because baseline shunt pressure should increase over time according to the physiological situation. Overdrainage protection, in our opinion, has to begin as soon as you're upright, and you become upright when your mother takes you on the arm and carries you around for 2 hours. You're already 2 hours in an upright position, even as an infant or a baby. And we need an increasing amount of siphoning compensation with growing body size. So these are some general things we can just subtract out of that basic principle. And on this background, we did an investigation to answer those questions. And together with our colleagues from Zurich, which have a very elaborate shunt simulator, situation simulator with an ICP compartment and abdominal compartment. This is the lying position, and you can bring it all in an upright position by moving the whole setup. And we adjusted that to simulate different age groups, 1 year, 5 years, and 10 years in children by adjusting all the physiological variables, all the height and weight situation, abdominal pressures, venous pressures, very elaborate software, trying to simulate the clinical situation according to the values available from the literature as good as possible. And we tested a standard differential pressure valve without any overdrainage protection, a similar valve, which is adjustable, plus 25 centimeters of water gravity unit, which adds 25 centimeter resistance when you're in the upright position, plus the same valve in a low pressure setting for 5 centimeters, and investigated what happens. This was a big task with 810 hours of measurements and 270 runs. And that are the main results. If we look at a 10-year-old child with a differential pressure and the child is laying or simulated in a lying position, the pressure stabilizes at around 10 because we have an abdominal pressure which comes in addition. And then when you stand up, you have the immediate drop because CSF and blood is moving out of the head. And then you have overdrainage. Everything that happens from that point is overdrainage because you have a continuous drain. You mobilize a continuous volume. The dynamics are getting less and less. And then when the child is laying back, it takes more than an hour of the pressure to come back. And here you see the effect if you cut the catheter to 60 centimeters instead of 120. The blue line is the line with a shortened catheter. So there's a significant impact of higher volume because a shorter catheter gives the whole system a lower resistance. And that is of importance. So if you cut the catheter, you make the shunt prone to overdrainage. And there is no reason to cut a catheter. So we put the full length of catheter in a 2,000-gram child. So no excuses for not putting in a whole catheter because you guarantee a second operation and you make the shunt system prone to overdrainage. That's the first measure. If you put in an overdrainage compensating device with 25 centimeters of water, and we have the same situation of a 10-year-old, you see after standing up, there's almost no drainage anymore. We still see a little effect between the dotted and the blue line of a shortened catheter, but not that big as without overdrainage protection. And the pressure when the child is laying up comes immediately back from the physiological slightly negative pressure, where it remains and fills up to the normal pressure within a short time. So for a 10-year-old, overdrainage protection of 25 centimeters of water totally annihilates the effect of overdrainage which would normally occur if you have no protection. And we already saw at 1 year in overdrainage, the first recognizable overdrainage in the situation. So it starts very early, even at small dimension. It increases at 5 years already to borderline negative intracranial pressures. And at 10 years, we have these very pathological intracranial negative pressures. And that's when most of the overdrainage symptomatology starts, mostly in children above 10 years of age. And with the pressure, with a gravity unit, you can totally cancel that out. And if you have a low pressure setting, then this is not enough. Even at 5 years, it starts already to be significant. And at 10 years, it's getting much worse if you have a low pressure setting. So overdrainage in non-protected shunt system starts at 1 year. In the medium pressure setting, in the low pressure even earlier. And you should use something to cancel that out. And if the child is old enough, 5 centimeters of water opening pressure is not enough anymore at the age of 10 years. So the second thing I want to cover are non-invasive methodology to monitor ICP and elucidate the role of papilledema, and also to tell you how you can monitor ventricular size without using CT or MRI. And that all works with ultrasound. The optic nerve shaft is the water around the optic nerve, which you can see here, the optic nerve in the middle, and the water around, which is in free communication with the intracranial subarachnoid space. Thus, if the intracranial pressure increases, your optic nerve shaft, which is elastic and is not limited by bones, will increase as well. And if the pressure comes down or becomes too low, the optic nerve shaft is going to disappear. So you have this window to the intracranial compartment, and you can measure that by MRI, as you have seen, as you can see here on the left side. But you can do this equally good by using an ultrasound probe, 10 megahertz, bigger than 10 linear probe with a low mechanical index, which is on all standard ultrasound machines, a linear scanner. And you see, you can equally nice, like an MRI, see the optic nerves in the middle, in the lower right, and the optic nerve shaft around it. And we have extensively evaluated that tool, first starting looking at MRI and ultrasound, and we see there's extremely good correlation between ultrasound and MRI. And the Blendon-Altman plot shows that there's almost no deviation. It's less than 0.1 millimeter of bias between ultrasound and MRI. So ultrasound is as good as MRI, and you can do it at the bedside, and it's better than MRI because often you have not hit the optic nerve in the MRI scan if you don't do very thin cuts through the orbit. The question is, how does it relate to ICP? There are well-established normal values for children below 1 year. It's pretty low, smaller than 4 millimeters, and then it increases over time. And we looked in 27 patients with invasive measurements determined by various means under general anesthesia or awake or sedation. And that is the plot. So you have a pretty good correlation, R of 0.63 in children above 1 year. In children with open fontanelle and a soft skull, it does not work. You see the correlation index is pretty bad in these children. So it is really only reliable if the fontanelle has closed and the child is older than 1 year. But if we look at that and we calculated now the threshold for an ICP above 10 millimeters of mercury, and we have a very, very good rock analysis here with a high sensitivity and specificity of 100%. So a cutoff value of 5.3 millimeters tells you that the ICP is pretty likely to be above normal limit of 10 millimeters of mercury. And if the ONSD is above 5.7 or 5.8, your ICP is very likely not as good, but still 91 and 66% above 20 millimeter of mercury. When we looked at almost 230 patients which had no therapy and those that had an intervention, the ONSD, which kind of predicted that this child needed clinical intervention, was again 5.3 millimeter of mercury. So 5.3 is something you can remember. If the ONSD is above that in a child, there is a very high likelihood that the pressure, intracranial pressure, is increased and that there's clinical relevance. The important thing is the intra-individual comparison. So in 10 patients, which you can see here, we have more than 3 ICP and ONSD pairs. And when you look at that, the general correlation of 0.78 in the individual is about 1.0 in almost everybody. So each patient has a very, very linear curve between ICP and ONSD. And if you have serial investigations and in your patient, the ONSD increases, you know his pressure is going up because there's a linear relationship in the individual between ICP and ONSD. So very reliable tool to look over time in these patients and tell you if ICP is going up. And we're jumping about that. Now the question is, how does ultrasound ONSD? And you can also look at the optic disc elevation in these patients by using ultrasound, which is ODE here, optic, versus papilledema, because papilledema is the standard to assess intracranial pressure. So we looked at 70 children, very brand new data, prospectively collected. 50 had a proven pathology for raised ICP and needed treatment because of tumor, hydrocephalus, pseudotumor cerebri, or whatsoever. This is the treatment group. And in 20 patients which were symptomatic, any pathology was excluded. That's the non-treatment group. And in 28 of these 50 patients, or 28 patients, we had fundoscopic findings, and ultrasound were compared to invasively measured ICP. So what did we find? First thing, and that is known from literature, only 50% of the patients which are in need of treatment have papilledema. So if papilledema is existent, it's a nice thing. If papilledema is missing, it doesn't tell you anything. Especially, it does not exclude raised intracranial pressure. And in our group here, you see the patients, the gray one is with papilledema, the darker one are no papilledema. So in the treatment group, about equally, there's no difference in ONSD. Those who have papilledema have an equally raised intracranial pressure or elevated ONSD than those that have shown no papilledema. So ONSD detects raised intracranial pressure in everybody, whereas papilledema only in 50% of the cases. And those which did not need any treatment had a normal or much lower ONSD. The optic disc elevation, which is the ultrasound correlate of papilledema, was similar. Those patients who had no papilledema also had a much lower optic disc elevation. So basically we see with the ultrasound the same thing an ophthalmologist sees, just we don't need to have an additional examination. We can do it in the same ultrasound examination. And in those where we measured the ICP, you can see those with papilledema and those without papilledema had equally distributed ICPs, also to a very high range. So we have patients with 45 millimeter of mercury, no papilledema. And those that did not need treatment had, of course, much lower ICPs in the no papilledema group. Looking at the minimal optic disc cutoff value, which you can actually, you need the elevation so that an ophthalmologist sees papilledema as 0.67. So if you measure an optic disc elevation by ultrasound, which is bigger than 0.7 millimeter, the ophthalmologist is going to see papilledema. If it is below, he's not going to see it. And you see this is an excellent ROC curve. So that is reliable what you see in ultrasound compared to the optic disc, to the fundoscopy. And here you see the ROC curves. The black line is that ONSD is superior to anything else. The gray is optic disc elevation, which is a little bit better than fundoscopy, because, and therefore the combination of ONSD plus optic disc elevation in ultrasound is not making it much better. You never reach ONSD as a single value. So why should we then use optic disc elevation at all? as an ultrasound parameter if it is not better than ONSD. And the reason is what you're seeing here. We graded these in 3 grades. Grade 0 is nothing, grade 3 is very bad, and all these patients had papilledema. So all patients of grade 3 have papilledema. But important is group 2. If you are in group 2 and have an elevation of 0.3 and 0.67, the positive predictive value for pathology is 90% and the odd ratio is 11. So even if you are uncertain about your ONSD determination, you see the optic nerve here, you can nicely measure the ONSD, but also the height here is telling you that patients of grade 2, these are the ones which, in addition to high ONSD, are going to need treatment. So using ultrasound in one go, you basically don't need the ophthalmologist at all to confirm your findings because there's a correlation with optic disc elevation, and that's what the ophthalmologist sees. So coming finally to the assessment of ventricular size, after closure of the fontanelle, you normally do CT scan or MRI, but you can do the same by using, again, ultrasound in the same go when you measure the ONSD. You need a transtemporal ultrasound, which you use with a cardio echo probe, which is on all standard ultrasound machines available. And this has been established in neurodegenerative disease with normal values, which are known in children and adults. And we have been investigating several questions to see whether this is a reliable tool for pediatric neurosurgery, because in more than 90% of the children, you will see the third ventricle for sure. You start at the mesencephalic level. You see the mesencephalon here. You see the cerebral peduncles, the interpeduncular fossa, and then you see the substantia nigra. This is the aqueduct, and that is the standard cut through here very horizontally. And if you tilt it a little bit up, about 10 to 15 degrees up, 20 degrees, you come in the third ventricular space here, and you can very nicely see the 2 walls of the third ventricle, and you measure across here, and you have the third ventricular diameter. And this are 3 examples in 3 different patients, and we compared this, of course, to MRI, and what we see is an extremely good correlation between that what you measure in MRI and that what you measure in ultrasound. So you don't need MRI or CT scan to know how large is the third ventricle. With, again, a very, very high Blandon-Altman plot with a bias of 0.1 millimeter, which is clear that there's a bias because here in MRI, I measure horizontally, here I measure slightly oblique, and therefore in ultrasound, it's 0.1 millimeter, which is not a lot, 0.1 millimeter, which is clinical of no relevance. So you can fully rely on ultrasound to determine the width of the third ventricle. The question is now, does changes of the whole ventricular size, or are they reflected in changes in the third ventricle? And that, as Susanne, it's all the work of Susanne Kerscher, my co-worker, and she has very elegantly demonstrated this in more than 400 or almost 400 MRI and CT scans in 170 children, where we measured the relationship between changes in the third ventricular diameter to changes, for example, here in the Salamedia index or the 4 or the Evans index. And they always see a very nice correlation here between decrease of TVD and decrease of the other parameters after treatment of hydrocephalus. And the same happens at shunt dysfunction, acute shunt dysfunction. The increase of TVD nicely correlates to the increase, for example, here Salamedia index or frontal-occipital horn ratio, whatever you want to take. So ultrasound of changes in the third ventricles totally reflect what is happening in the lateral ventricles, unless you have foramen Monro occlusion as a specific type of hydrocephalus. And you see again that what we found in ONSD, that the individual patient, the correlation in the individual patient between 4 index and TVD is very close to 1.0, so a linear relation in the individual patient between changes in the third ventricle and the lateral ventricle. So if you have serial investigations in the patients and your TVD suddenly goes up, you know for sure that the ventricles will be larger. You don't basically need MRI and CT if you trust your methodology and if you are experienced enough to do so. And this is published now, so these data are out, and there is a value behind it also from the medical legal point of view. So in summary, ultrasound aided management of hydrocephalus in children is something we can really wholeheartedly recommend, because it really has changed the game completely in our setting. So we do it in every routine visit. We look at individual normal values when the child is well. And then we follow them over time. When you adjust the valve, you can see whether the ventricles go up or down. You can nicely see that by measuring the TVD. You can detect silent or over or under drainage. Suddenly the child has no symptoms, but suddenly the TVD goes up, the onus D goes up. You know he's developing pressure and his ventricles are going to enlarge. When there is query shunt malfunction, the child comes into the emergency room and normally it immediately gets a CT scan or an MRI scan. If we see that the onus D is unchanged and the TVD is unchanged, we can be sure, because the negative predictive value is about 100%, that this child has neither ventricular enlargement nor increase in intracranial pressure. So we do nothing. We put them on the ward and find out what is the real reason for vomiting or not being well. No shunt puncture, no CT scan. And of course, if we see changes in the beginning, we did MRI and CT for medical legal reason before going to the OR. In the meantime, if everything is clear, we go to surgery without any additional imaging. After shunt revision, you can nicely monitor the recovery of the patient. You don't need post-op CT and MRI scan to be sure that the ventricles become smaller and that the intracranial pressure comes down. So you can use the same thing, of course, to monitor the efficacy of ETV. You don't need a post-op CT or MRI to see if there are any changes. And you can nicely monitor if the pressure comes down after ETV or whether it stays up. So it has replaced most of the scanning. It has replaced shunt puncture in most of the indications, unless you want to rule out infection, and really has changed the game. Thank you very much for your attention.
Thank you, Martin, for this very interesting speech. So, and as I see that the majority of questions are answered by the speakers, so it is no need to answer perhaps them during our webinar. Instead, I want to discuss one topic. So, and it was initialized by the question of Ayman Mayas. So he asked how to recognize the hydrocephalus arrested. So I think this is a very philosophical question, and really, what do we want to reach? What point at our treatment? So we want to obtain the normal development of a child, or the or no papilledema, or the normal size of a ventricle or of the head. What is our purpose of our treatment? So, and I think that our experts may answer this question. And Henry, what do you think about the arrested hydrocephalus?
So that is very, very difficult. I think we had some kids where we make an ETV because they were symptomatic, and they stayed with larger ventricles, what they improved. So we sent them back, and then some of these come back after 8 years or later, and then again they are symptomatic. So there was a slowly progressing hydrocephalus which was not recognized by the caregivers. And that is very difficult, because usually we only treat patients who are symptomatic. Frequently you see dilation of the ventricles as an incidental finding. And if they have no problems, we just advise to follow them up. But you know, if they are good, sometimes they do not follow up, and then you see later progression of the hydrocephalus, and then it becomes very slowly progressing. So in chronic hydrocephalus, sometimes you have such a slow course that nobody is recognizing it. And that is the difficulty, in my opinion.
Mansoor, what do you think about it?
It's a good question. I think essentially it comes down to basic formula and rules that is it worth intervention if they've got arrested hydrocephalus, whether a child or an adult? And if they've got a shunt in place which is blocked, it's one thing. If they haven't, another. Let's take a scenario of an adult who's had a likely event or long-standing hydrocephalus, and they've accommodated that scenario for a long time. We just wouldn't intervene prophylactically to stop them, for example, getting an NPH scenario. You would wait essentially till the patient develops symptoms and or signs to make that intervention justifiable. And I think we're detecting a lot more of such adults who've had hydrocephalus onset as a child or in a younger life, and then have become symptomatic following an event later on. And I think there's a nice group of these patients. So essentially I think the ethos should be when you would treat the arrested hydrocephalus when it is worthwhile treating with the risk versus benefits, and not before. So you would need either significant symptoms or clear justification that they're going to deteriorate, and that chance of deterioration is so significant that it's worth intervening for.
As such, I think there is no arrested hydrocephalus. I think this is a misterm. What is it? We have sometimes residual hydrocephalus after an active process where we have white ventricles, but it's not an active hydrocephalus. What is arrested hydrocephalus? I think there is no arrested hydrocephalus. There's a chronic, slowly progressing hydrocephalus, in my opinion, but the term arrested hydrocephalus, I think this is a misnomer.
You know, I remember one of my patients. So I was on the consultations, and I saw the next patient was a girl about 12 years old. So she came into my room, into my office. So, and I noticed a huge diameter of her head, about 70 centimeters. So, and I looked through her MRI scans, and there was a very thin line of the brain around the huge ventricles. So I asked her, where is your mother? How can you, who accompanied you? She told me, oh no, my mother left in my house with a baby. I was amazed. So how could this small girl come to Moscow? So, and I asked her, what is your complaints? What is the problem then, with which you have come to me? So, and she answered, oh no, you know, I study at school and I have a bad marks in studying English. So it was in Russia. So, my God. So, and so is it a case to study hydrocephalus? So it was a huge ventricles, and this girl was completely socialized. So, and I'd like to say that perhaps this is, of course, it was maltreatment of the hydrocephalus in her childhood, in the very young age. But this is the peculiarity of the hydrocephalus in children. An adult person with such a size of the ventricles will lie in the intensive care unit or in the cemetery. You see, this is the hydrocephalus of children. So, what are the thoughts about the peculiarities in this period of life? Because then we shall come to the transition period and then to the adults. So, Marianne, what your thoughts about how do the hydrocephalus in children differ from the adult one?
Wow. I don't think we can stop until tomorrow morning if I need to answer that. I think hydrocephalus in children differs in almost every aspect. The etiologies are different, the symptomatology is different, the dynamics of growth and CSF dynamics are different. And I think this is why it is particularly difficult to address the question of children growing up to become adults with an original pediatric type of hydrocephalus, where some parts of the scenario become adult, and other parts of the original hydrocephalus is still within the pediatric hydrocephalus scenario. And I think, in my mind, that is particularly difficult. And I agree completely with Martin that part of the answer is to identify problems with our treatment before chronic complications arise, which they then carry into adulthood when it becomes so chronified with lack of compliance that it's very, very difficult to do something about. I think a lot of this borders on our lack of consensus in how to follow up and when to follow up and how long to follow up. And I think we need to make a change here from follow-up defined by chronology, dates and timing, towards identifying a physiological follow-up where we identify what to look for at particular stages along this patient course in the hydrocephalic life.
Okay, thank you. Thank you, dear colleagues. I think now we have to move further. And while I am trying to share my presentation, so this is my own presentation. I hope that you see it. So, and my report is not devoted to a certain clinical entity, but deals with the organizational issues of healthcare transition between the childhood and adulthood. What is the healthcare transition? So this is the move from the pediatric to the adult healthcare system. For example, in Northern America, it's about 10,000 person who needs this process. Each year in the United States, for example, it is about 5,000 to 6,000 adolescents and young adults with congenital or acquired hydrocephalus. In Russia, it's about 3,000 to 5,000 persons. So you can see this is the great amount of persons who need to be treated further in their life, in their adult life. So despite the publication nearly a decade ago of a detailed article on the population needs for transitional care of hydrocephalus, to my mind, little progress has been done. So this is very important graphs. And on the left, you can see the Kaplan-Meier curve showing the overall chance survival in adult transition patients with pediatric onset hydrocephalus. You see that after this red line, a lot of patients should be treated in their adult life. So on the right, this is the patient follow-up. And you can see that on the other hand, we have a great amount of patients. And on the other hand, the follow-up also dramatically decreased, especially after the age of 15 years. So there we have a very important issue. So the origin of this problem is that neurosurgical diseases are generally acute, but successful management frequently transforms them into the chronic conditions. As pediatric neurosurgery tends to become an autonomous division, some neurosurgeons become exclusively pediatric, and the need for a transition from pediatric to adult care is felt more and more actually. So nevertheless, we have a lot of barriers on this way. So these barriers are attributed to the patient, to his family, to the pediatric caregivers, and to adult caregivers. So let us stop more, let us stop at all these points. So the first, patient and family psychosocial barriers. So the recent social trends have extended the pre-adult period into emerging adulthood, spanning ages 18-29 years, which is significantly later than the traditional ages of 18-21 years. So parents who are overprotective can inhibit in young adults opportunities to explore and develop independence in managing their own health care. So this is an issue of the poor compliance. So some young adult patients may be unwilling or unable to attend appointments. The fatigue with condition, many patients may show wariness or lack of initiative in managing their condition and rejection of the medical world. A long-term patient whose care has been managed throughout childhood may have developed an attitude of passivity and dependence. So the barriers in training and availability of key specialists. The pediatric neurosurgeons are well trained in the care of children with hydrocephalus, but few are formally involved in the healthcare transition methods. Adult neurosurgeons. Many neurosurgeons specializing in the treatment of adults profess an inability to manage complex hydrocephalus cases. Many neurosurgeons who treat adults only don't have an interest in the managing patients with shunts. And at last, the neurosurgeons not used to following shunted patients may not appreciate the need for the long-term follow-up of these patients. Neurologists have the potential to play an important role in the care of children and adults with hydrocephalus. However, they receive formal education in the pathophysiology, diagnosis, and treatment of hydrocephalus, which is not mentioned in the core competencies for the neurology and child neurology. Physical medicine and rehabilitation. Psychiatrists have a role in the care of patients who require long management for mobility, spasticity, orthosis, particularly for patients with hydrocephalus. But they may not necessarily require additional training in hydrocephalus. And at last, primary care. In areas with limited access to the neurosurgical care, primary care professionals provide the initial response to the patient's concerns about their hydrocephalus. But these specialists are often uncomfortable caring for patients with complex conditions, including hydrocephalus. So, and at last, the healthcare system barriers. So the infrastructure and care models are differ. So one is for patients to remain with their pediatric neurosurgeon after they become adults. But the model works only where pediatric neurosurgeons have privileges in adult hospitals, or where pediatric hospitals allow the admission of adult patients. So it is not a solution for the healthcare transition. So the second is for patients who have gone through healthcare transition to be seen in programs, in the special programs that specifically provide long care for adults with hydrocephalus. But we have only limited availability of such a program. So not commonly, fee structures don't adequately reimburse the practitioner for the time that is spent managing complex patients with hydrocephalus, and it may be a long time. So the lost records, so the poor organization of medical records is not uncommon and can result in the loss of patient's previous medical history when he comes to the adult medical care. And at last, the health insurance. You know that in some countries, persons with pre-existing conditions allows young adults to stay on the parents' employer-based insurance plan until age of 26 years, for example, in the United States. But children who have Medicaid or coverage through the children's health insurance program may lose coverage at the age of 19 years. So thus we have the economical problems. So how to solve all these problems? So we have 3 stages of healthcare transition. The preparation at approximately 12 years age, the transfer of care from pediatric to adult healthcare professionals at age 18, 26, depending on the local policies, and integration into adult care. So there was a very important hydrocephalus association transition summit in 2017. So, and they elaborated 6 core elements that describe a process to prepare patients for transition, to facilitate their transition, and integrate patients into adult-centered care. So, and all these 6 core elements, from one hand, is addressed to the pediatric healthcare professionals, and on the other hand, to the adult healthcare professionals. So, what are the benefits of organized child to adult transition? For example, firstly, for the healthcare system. So when a problem with a shunt is identified early, before it creates injury to the patient. So economic benefit results from the avoidance of complications, as has been shown for patients, for example, with spina bifida. For a patient, of course, the recognition of hypodrainage, and asymptomatic shunt failure, which requires the neurosurgeon's expertise, should be made in time. The management of associated diseases and handicap, the counseling on occupation or leisure activities. So all these privileges are for the patients who are incorporated into the healthcare transition mechanism. For a surgeon, of course, this is attraction of patients for his practice, the complete medical records, which available from the one hospital to another, and ease of clinical research. So what are the models of a child to adult transition? So no transition model. In units taking care of both children and adults, where the same physician continues to follow his patients regardless of age. Neurosurgeon to neurosurgeon model. Child is cared for a specialized pediatric unit, then he continues his treatment in an adult unit. In such a setting, close collaboration with an adult unit should be maintained to allow the follow-up and management in adulthood. Patient-centered model. For patients who are intellectually competent to be educated about their condition, emphasis had been placed on helping them learn about their disease and its treatment. Such education should be anticipated and begin long before the patient reaches adulthood. And at last, the rehabilitation-centered mode. For patients who are severely limited cognitively, the management provided by different specialists is best centralized under the direction of rehabilitation physicians. So one of such models, the patient-centered transition model, was described by the Matthew Wang Chong several years ago. And here you can see the patient in the center. The horizontal arrows represent network relations, vertical arrows represent transition relations. So this is very interesting paper, and I may address you to this paper. So we have another model, which was, so the variety of models, which were proposed by our Canadian colleagues not far ago, several years ago, and they define the 3 main clusters of the situations. The first is the pediatric neurosurgeon running adult hydrocephalus service, and there are several varieties inside this model. When adult neurosurgeon running adult hydrocephalus service, and at last the hybrid joint service. So, and you see, every of these models may be implemented in different countries. So nowadays we have no guidelines. We have no best transitional model. But looking at this slide, you can realize that there may be the whole variety of possible models which can be used in every clinic. So a very important moment, this is a transition file which is moved from the one hospital to another. This transitional file should include the medical history, the details of current shunt, the baseline imaging. Of course, all the images should be available in the adult hospitals from the children's hospital. Even the latex allergy should be included in such a file, and the pediatric neurosurgeon's contact information in order to his adult colleague to elucidate several questions which may arise during the treatment of such a patient. So, and I may say that in Russia now we have the central servers which include the electronic records from the federal hospitals, regional hospitals, outpatient clinics, and polyclinics. And this system is very valuable in our country, and in the several years it will cover all our country. So, and the last slide, again coming back to the Hydrocephalus Association Transition Summit, which was in 270. So this is the consensus recommendations of the hydrocephalus of this association. So it is differed it is addressed to the local level hospitals, to the and to the national level. So, and while you are looking through this side, I want to tell you that, to my mind, one of the most important things is the development of guidelines, where all these positions will be summarized and presented to both to the adult and childhood neurosurgeons and services. And such a work is now being conducted under the auspice of the pediatric section of the EANS, and I hope that it will be performed during last several months and will be presented at the Belgrade Congress in the October. So thank you so much for this attention, and I think that in the nearest years we shall present you the new view to this very difficult problem. Thank you.
Thank you, Sergey. It's difficult to be both a moderator and a speaker, which is why I'm stepping in right now. I can't see that we have received any written questions yet pertaining to your talk, but I think we could ask the panelists, Henrik and Mansoor, how transitional hydrocephalus is handled in the UK and how it is handled in Germany. So Henrik, please.
Yeah, so when the patients become 18, they will not longer treated or cared by the pediatric neurosurgeons or pediatric doctors, and they come to us in our OPD, and we change the files. They send everything to us. Usually we are involved already because, you know, we are a small department and we have some people who are subspecialized in pediatric or also make adult neurosurgery. So it's not that it's pure pediatric neurosurgery and this adult neurosurgery, so it's not a big transition. So we just get the files and we do the follow-up examinations. We have, depending on the symptoms and how long we are there on the follow-up, we have interval of performing each year 1 MRI. If they are longer, we just do it after 3 years, sometimes even after 5 years for academic purposes, because, you know, if they become symptomatic, they are advised to go immediately to the doctor, to the local doctor, and then they get the imaging. So it's not a big problem in our department because we are anyhow involved in all of these hydrocephalic children.
So that is because you're a mixed service. I think we would probably get a different answer from Martin Schumann and Uli
Sure.
Tomale, who run entirely pediatric departments and who need that sort of transition dialogue and transition exchange of information with their adult colleagues.
Yeah, exactly.
Right. So Mansoor, how does that look from your perspective? The question about solving transitional issues?
I think that's a very good question. It's a very similar system in the UK, and a lot of this was reformed and progressed following this movement called Safe and Sustainable, which many British neurosurgeons will remember. But essentially, those centres that have got both pediatric and adult neurosurgery, usually the patient will just stay under the care of that particular consultant who will just look after the patient in the same unit, and that's facilitated, and it has its benefits. And of course, if you're in a pure pediatric center, then you would be handed over to usually a dedicated team or a handover colleague who has an interest in hydrocephalus, and the provision of adequate records, particularly a kind of a passport, is very, very helpful. Now, that's fine, but I think the more important point that comes to mind in relation to this excellent presentation by Sergey is, to be frank, the work that was done with classification of hydrocephalus, I think by yourself, Marian, and group, because I think that's very pertinent to this. If we can come up and facilitate and agree internationally as group with an improved classification, it will make record keeping as one of the benefits of this. And I point to people and colleagues, of course, but particularly the audience, to look at the aspect classification that was done, and particularly looking at the various facets of it, be it anatomy for A and symptomatology, previous treatment, I think was for P, and etiology, and complications and time for aspect. And I think that was a very good piece of work, which should hone in the mind of the trainees, younger colleagues, consultants, anybody, to, when they see a patient with hydrocephalus, to look at what needs to be recorded from each of those letters. And of course, classifications have been allocated for each one of those, as we know. For example, in etiology, was it infectious, was it vascular, was it neoplastic, and so on. And the time, the last T of that aspect is in relationship to which stage of life they are in hydrocephalus. So I would advocate that, and I think that's a very good piece of work that's come out of Copenhagen, supported by the CSF task force and others. And I commend you, Marian, and the group to have a look at that. Thank you.
Thank you very much, Mansoor. We hope this will be published in ACTA, where it's currently under review. But nevertheless, I think that Sergey also stressed that keeping a record and ensuring that all necessary information is recorded and transferred is a key point in taking over treatment and continuing elsewhere. So regardless whether this is the aspect system which we have been working on, or another system, a complete and comprehensive description of the patient's history is absolutely necessary. I think we're running a bit behind, maybe. So, Sergey, should we go on with the next two speakers?
Yes, I think that we are moving for the older and older age, and now so Marianne, we have to invite yes, Professor Lawrence Watkins from United Kingdom. Yes, Lawrence, with the speech devoted to the hydrocephalus in adults. Yeah, you are welcome.
Good. Well, I'm going to just share my screen since I can get the slideshow going.
Yes. Yes. Excellent.
So this is part of the overall theme of this webinar, the 5 ages of hydrocephalus, and I'm going to talk about hydrocephalus in adults. And this is where I work at Queen Square in London, the National Hospital for Neurology and Neurosurgery. And these are my conflicts of interest. This is how it fits into the overall session that we're having. So we've got, this is my one in hydrocephalus in adults, really in the 18 to 65-year-old age group, with Uwe Keller is going to talk to us about the over 65s a little later on. So hydrocephalus is often loosely referred to as just the excess of cerebrospinal fluid. The things to remember is that it's a lifelong condition in most cases, fairly high prevalence, about 1 in 1,000 overall. And of course, there are acute and chronic forms. Acute I'll cover briefly, but the chronic forms are the majority of those in an adult hydrocephalus practice, sometimes referred to as GIA, chronic hydrocephalus in adults. Quickly to cover the acute hydrocephalus, which all neurosurgeons deal with to some extent. Subarachnoid hemorrhage, meningitis, tumors causing a blockage, colloid cysts being a benign form of lesion that can do that. And then in people who already have a shunt blockage can lead to an acute hydrocephalus. And in each of these cases, the intervention will be to either offload the CSF to the external world or to revise or remove the blockage. And the thing I would encourage you to remember is that even if you have an external drainage device, you can also put in an intracranial pressure monitor to double check that your drain is having the desired effect in reducing intracranial pressure. So this is a typical external ventricular drain through a burr hole and tunneled through this, in this case, right frontal region as an acute treatment for hydrocephalus. But in most cases of chronic hydrocephalus, that's not necessary. In associated conditions, which if you're in an adult service, you will also be dealing with, intracranial hypertension, sometimes treated with shunts, sometimes treated medically, sometimes treated with venous stents, and related spontaneous intracranial hypotension, which is a very important topic and difficult to analyze and treat, but there's a lot of advances being made in this at the moment, particularly in the imaging of things like CSF to venous fistulae. So of the various classifications, there are many, including the aspect one that we were just talking about, but these are the groupings which are currently referred to in the literature. So, and most of them are referring to either the age of onset or the pathology of the blockage or the progress of the disease. Hakim syndrome or normal pressure hydrocephalus is going to be covered in the next talk, so I won't go into that in great detail. Then there's the midlife hydrocephalus, the majority of the adult hydrocephalus, sometimes called LOVA, long-standing overt ventricular megaly in adults, or sometimes Scheimer, syndrome of hydrocephalus in young and middle-aged adults. Controversially, sometimes called unrecognized congenital hydrocephalus, with the assumption that in fact the patient has had it for many years by the time that they present. And the presentation in a clinical situation depends on the age of the patient. It's interesting that this is a condition where the presentation depends more on the age than the underlying pathology. So in an early midlife hydrocephalus, the typical things that we see are headache and visual problems, sometimes imbalance or even syncope and seizures. Whereas a late onset hydrocephalus very often looks like the same as a normal pressure hydrocephalus triad in the older patients. So the prevalence of each of these things tends to be dependent on the age. This is a sort of extreme case of LOVA with very large ventricles, obviously a very chronic condition that has existed for many years before it presents. And then there is a group which often called secondary chronic hydrocephalus, where there's a precipitating factor. The patient has had a subarachnoid hemorrhage or a head injury, perhaps an episode of meningitis, within 3 or 12 months prior to their presentation. If it's less than 3 months, it usually gets included as an acute hydrocephalus. If it's more than 12 months, it tends to be less certain that the first event led to the hydrocephalus, so you're less likely to assert it. But in the in-between part, you usually referred to as a secondary chronic hydrocephalus. We did talk a little earlier about compensated or arrested hydrocephalus, and we were hearing that some people believe there's no such thing as a completely compensated hydrocephalus, just very slowly progressive. And this can also be asymptomatic in some people and picked up on a scan when they really have got no other symptoms. But sooner or later, they often do get symptoms. So calling it asymptomatic ventriculomegaly is not true in a lot of cases. And as you can see here, the commonest presentation is headaches. In the majority of people who present with any symptoms, the majority are going to have headaches. And then a growing group of adult onset genetic associated hydrocephalus. So these are not the ones that are obvious at birth or even before birth, but gene-associated hydrocephalus presenting in patients who are more than 18 years old. And this is a growing group, not because it's becoming more common, but I think because our understanding of genes is becoming better. And so with better gene analysis and more easily available, we're going to learn more about these genes which are associated with adult onset hydrocephalus. And so I think this will be an increased group in future talks on this subject. These are the genes that are already in the literature, and this is a growing list as more become apparent. So watch this space. Genetic influences on hydrocephalus is going to be something that we learn more about in the next few years. A lot of the genetics are, as you may have noticed in that last table, to do with abnormalities of cilia. And this is a typical picture. The top one is the inside of the ventricles with a lush wheat field of cilia lining the ventricle. And the bottom, more serious hydrocephalus with denudation and malformation of the cilia, and even patches where the stem cells in the periventricular region are exposed. We heard a little last about transitional hydrocephalus, where patients are actually in transition between pediatric and adult services. There's also transitioned hydrocephalus in my practice, where patients are older but have had their hydrocephalus since childhood. And in the Adult Hydrocephalus Clinical Research Network, the mean age of this group is in the mid-30s. In this group, quite often other symptoms are predominant. Seizures and learning difficulties or psychiatric disorders are more common, and they are a very important group in terms of managing long-term complications. In this group, sometimes you see this pattern of which is often referred to as posterior hydrocephalus. This almost always means that they've had an early childhood hydrocephalus at some point in their history, and although they have survived through to adulthood. So if you're dealing with adult patients in the outpatient clinic, what are the useful things? I think this is probably one of my most useful slides. These are the things that I do in clinic. Look for in the eyes for papilledema and spontaneous venous pulsations. If you can see spontaneous venous pulsations, that almost always means that the pressure is not critically high. Otherwise, you lose those SVPs. I look at head circumference because that gives you some guide as to whether this patient has had their hydrocephalus since childhood. And I'll show you a slide in a minute of the Bushby criteria for working out whether an adult's head is big compared to the average. If they have any gait symptoms, we do a 10-meter timed walk, looking at gait assessment, counting steps, and looking at the time to cover 10 meters. Another test often used in the clinic is to put the patient on the couch, supine, and ask them to pedal an imaginary bicycle in the air. Most patients whose gait problems are due to hydrocephalus are perfectly able to do pedaling because they have no ataxia, they have no focal weakness, but they have a gait apraxia where as soon as you put them upright, then they have trouble walking. But if you put them on their back and ask them to pedal the bike in the air, they can do that very easily. So that's quite a good screening test. The other thing, postural drift in the upper limbs, because if they have postural drift on one arm, then that is unusual for hydrocephalus alone, since hydrocephalus tends to be symmetrical. And so if you have postural drift, you've got to think, have they had a vascular event, or have they got a chronic subdural, for example? These are the Bushby criteria for looking at adult head circumference. They look very similar to the charts you might see in a pediatric clinic, but in fact, the x-axis on this is the height of the adult patient, and then looking at the head circumference and showing you where the 50% mark is, where the majority of patients will be around that, or if they have very small or very large heads compared to the average for their height in an adult. So adult hydrocephalus is increasing steadily, and all of the units that deal with it are seeing this increase in numbers. That's partly due to an aging population. In many developed countries, increasing body mass index and an increase in metabolic syndrome, leading to increased intracranial hypertension. And whatever you're in, if you have better survival of premature and early childhood illnesses, you will get more post-hemorrhagic hydrocephalus and a greater need, as we were hearing, for transitional clinics and the ongoing adult services to look after those patients in the longer term. If you're a trauma center and you have a good survival rate from head injury, you will get more post-traumatic hydrocephalus, more syndrome of the trephined from the reducing their ICP with craniectomies. And even if your practice is mainly tumors or spinal, you will also need to deal with CSF problems, either hydrocephalus or leaks. So the traditional view of hydrocephalus is that you get a blockage and then a buildup of fluid upstream, like a dam across a river. And sometimes it is that simple. But an increasing understanding is that although this is a typical sagittal MRI that we would see, it is in fact a snapshot, a false picture. And the reality of the physiology is that it is a dynamic picture with CSF moving and the brain moving with each cardiac cycle. So from a human point of view, we are given a solid skull, but a pulsatile heart moving our blood around. And that is something that we all have to live with. And so with each cardiac cycle, arterial blood is pushed into the tissue of the brain, and CSF has to move out of the way temporarily to make space for this pulse wave. And so you get a movement of CSF down through the spinal canal into the lumbar theca. And the lumbar theca is padded by an epidural veins, which directly connect to the inferior vena cava through valvular systems. And so there's a two-way flow absorbing that pressure wave into the venous system with each cardiac cycle. And this understanding means that anything that's obstructing the flow of CSF can also lead to symptoms and problems. It's not simply a blockage, but sometimes an impairment of this alternating flow. So we were hearing a little earlier about how it's difficult to differentiate adults from children, but this is how adults are different. For one thing, they have a very low complication rate compared to pediatric hydrocephalus and a much lower infection rate. The presentation is very variable. So in some people, it's going to be gait disturbance. In some people, it's going to be tinnitus. It's very different in individuals. And the other thing is that most patients with chronic hydrocephalus are at least partially compensated. Their shunt is not doing all of the absorption of CSF, and some of their normal absorption mechanisms are still functioning. And so they tend to deteriorate much more slowly than children, sometimes over weeks with a blocked shunt. It's therefore unusual to operate on a chronic adult hydrocephalus patient at night. And there's a much greater use of intracranial pressure monitoring in infusion studies, analyzing CSF compliance, because the symptoms are often not a pure guide to what to do. Another way of saying the same thing is that this is the revision rates from the UK shunt registry, a huge registry of tens of thousands of patients. Pediatric at the top have a high cumulative revision rate. And then the older the patient, the lower the cumulative revision rate. And in fact, the over 70s have a very low cumulative revision rate. The other thing, as you can see, is the difference between fixed and adjustable valves is more important. There's a greater advantage to adjustable valves the older the patient. And so I would sum up that the philosophy of hydrocephalus is really that it's not a single clinical event. A patient presents, you do something, they go away. It's more a management of a long-term condition, more akin to diabetes or cardiac disease. And our job as adult hydrocephalus surgeons is to reduce the number of interventions and the associated risks and minimize the cumulative complications, some of the strategies for that we heard earlier on, and maximize quality of life, optimize quality of life by our management. So I'd like to thank you for your attention to that brief overview of adults and how they differ from children. And thanks to my great team here at Queen Square. It's a very big team, but they're all extremely good and contribute to everything I do. Thanks.
Thank you, Lawrence. Thank you, Lawrence. As far as I could understand, the main difference between the child and adult hydrocephalus is that shunting procedures in adults never performed at night.
Yeah, it's surprising. With chronic hydrocephalus, patients sometimes turn up in clinic with saying, my walking is slightly getting worse. And they've obviously had a blocked shunt sometimes for many weeks before they present. Unlike the children next door in our pediatric hospital at Great Ormond Street, who can go from being well to in coma within hours. That's extremely unusual in adults. It's not impossible, but it's unusual.
Yes, and on the contrary, in children, this is one of the main emergencies in the pediatric neurosurgery.
Yeah, that's right. So I think that you're right, Sergey. That is one of the major differences in strategy and psychology of the surgeon dealing with adult or pediatric cases.
Okay, so the questions appear with I think the questions will appear in several moments, and so I ask all the speakers to look through the questions and answer them. And before we shall proceed to the last report, I want to announce one question. So this is the question from Magda Garçon. I've inserted more than 400 of shunts in children, but recently I started to work in adults. Because of the population is getting older, I have inserted a good amount of shunts in the last 18 months, and frankly now I think is equally or even harder to get the shunt settings right for the purpose. So I think that I can ask all our panelists and experts to think for the answer of this question. It is really the second philosophical question, how to choose the shunt for the treatment of hydrocephalus in different ages. I think that we shall answer this question after the last report, and all our participants, those who will stay with us, will know the answer for this exciting question. Okay, so any other comments or questions to the Lawrence?
I think we're all keen to hear Uwe's talk now and to complete the 5 ages.
Yes. Okay, so then let us come to the last report, and then we shall discuss everything that we want to discuss. So, and that's why, sorry, Marianne, I am speaking and speaking, so please, please take the discussion in your hands.
Thank you, but I think we will go on to Professor Uwe Kehler, and then we'll will sum up some of the questions, including your quite provocative and difficult question, Sergey, and try to answer that at the end. I think that will be a very nice way to sum up what we've been concentrating on this afternoon. But please, Uwe, enlighten us about normal pressure hydrocephalus or hydrocephalus in the old age.
Well, thank you, Marianne. Thank you, Sergey. It's a big honor for me to be here. Can you see my screen?
Yes, excellent.
Okay, very well. Yeah, here you see a poor patient with normal pressure hydrocephalus. He was he found them, this guy 5, 6, 7 years ago with gait impairment. They did diagnostics, they did spinal tap tests, they did see an improvement. Then they said, yeah, there's improvement, but it's not good enough. So probably it's no hydrocephalus. Again, they did it. They said, then, yeah, we are not sure. Probably it's too dangerous. And then he was old and in very bad condition and said, yes, it is a hydrocephalus, but now he's too old. He is too sick. We cannot do any surgery anymore. And well, unfortunately, this is the result of therapeutic nihilism. Well, I'm going to talk about in the next minutes about hydrocephalus in old age, which means mostly normal pressure hydrocephalus. Here are my conflict of interests. Hydrocephalus in old age, so older than 65, this is 95% normal pressure hydrocephalus. There are some other cases with obstructive post-hemorrhagic and other entities which were discussed already in previous lectures. Well, if I talk about normal pressure hydrocephalus, of course, I have to talk about Solomon Hakim, who described it first. And from him, we have the symptoms with the Hakim triad, with gait disturbance, with dementia and incontinence. And if we have this together with a ventricular enlargement and a normal ICP, a normal intracranial pressure, we talk about normal pressure hydrocephalus. Well, if we just look at every people at normal aging, probably with 80, 85, we get some gait impairment. With 90, we may be bedridden, and with 95, 100, we are going to die. Everybody of you who are listening here, you cannot skip this. But if we have normal pressure hydrocephalus, the timeline of this deterioration is shortened very much, and very much earlier you will have your dependence, and you will also die earlier. I will show you a little bit later. It's very important to know the natural history, and this is a very nice a publication from Andrein, and she looked at patients who were diagnosed with normal pressure hydrocephalus, and the surgery was delayed. So this first at diagnosis, and this just before surgery, and this was more than 6 months in those cases. And you could see with normal is natural history of INPH means NPH symptoms progress. And also, if you do operate them later on, she could show that the delayed surgery is correlated with a worse outcome. So just if we look at the epidemiology, we just look at newer and newer papers, the incidence and prevalence is higher and higher. And nowadays, we would say that about 4% of the people older than 65 will have normal pressure hydrocephalus. If you look at nursery homes or falls clinics, you will see very high prevalences. And Lawrence already said it, with the aging development of our societies, this probably will be even more and more severe in our clinical daily practice. Well, why is it so often? And what is the pathophysiology? We must say we really don't know it very much, but we know that most of the patients with normal pressure hydrocephalus have some vascular diseases. And how does we think it could be, or at least a part of the development of normal pressure hydrocephalus. How does it work? The heart is just pumping the blood with a very high pulse pressure. And if the vessels are still normal and elastic, this high blood pressure or this pulse pressure is just transformed to an almost laminar flow. And this goes to the brain and to the capillaries. But when we are getting older and the vessels are getting older, more stiff, especially also with patients with hypertension, with diabetes, smoking, they will have rigid vessels, and the rigid vessels cannot transform the pulse pressure to this laminar flow, and they will give the high pulse pressure to the capillaries. And that means this high pulse pressure is hammering on the brain. And on the other side, the water of the brain, the CSF, is not compressible. So this is very hard. It's like a stone. And you just see, if you just hit with a bottle of a stone, it will break immediately. And you can understand that this is not good for the brain as well. And we know that most of patients with normal pressure hydrocephalus have some vascular disease. So NPH is more or less a vascular disease. Well, the symptoms I already said about that we have the Hakim triad, but the Hakim triad is not present in all patients, but in almost all patients there will be gait impairment present. But you will have the whole triad only in 50%, and other papers it may be 60, even 70%, but never 100%. Very rare, you will have only incontinence or dementia, isolated. A gait disturbance is more or less mandatory. You see here one patient with a typical gait disturbance, normal pressure hydrocephalus, atactic, broad-based, slow, short step, magnetic gait, shuffling, and you see the very good swinging arms. But this is in very advanced cases. If you look at beginning cases, it's very difficult to see. At early stages, the changes are very slight. Very often the people just tell you somehow there is something, but you cannot detect it, or it's very difficult to detect. Patients just report about a disbalance. And if you do gait tests, they are normal. And especially if the patient has to walk in front of your eyes, they will be concentrated. And with concentration, they can compensate the gait disturbance. So gait disturbance at early stages of NPH are often not detectable or very difficult to detect. And especially during the examination, patients are concentrated and they can more or less compensate the gait disturbance. So the urinary incontinence, this just usually starts with a high frequency. But high frequency really doesn't tell us anything. It may be heart disease, maybe heart insufficiency or something like this. But if it's progressed, you will have an urge incontinence. And if it's progressed even further on, it's a complete urinary incontinence. At the beginning also with the urge incontinence, you may have problems if there is severe gait disturbance, because maybe the patient will not reach the toilet because of the gait disturbance, but otherwise it could be quite fine, the the bladder function. But we will have, if we just look at all our patients, urinary incontinence about 60 to 80%. What about fecal incontinence? If you just look at the literature, very often there is stated, well, fecal incontinence is quite rare, and normal pressure hydrocephalus. Sometimes it's even stated if there is fecal incontinence present, look for different diagnosis. We looked at our patients, we presented it last year, and now we have a larger series. Even fecal incontinence was fecal urgency or complete fecal incontinence. This is about 1/3 of the patient with normal pressure hydrocephalus. In elderly, it should be only in the same population 15%. So that means that in NPH is a double as it is in the general population in this age group. And what the good thing, fecal incontinence very often improves after shunting. And of course, the third symptoms is dementia, especially with psychomotor slowing. Very often you have impaired short-term memory, impaired attention, concentration, and in the late stage, it looks like akinetic mutism. Quite often, we just ask our patients something, we don't get an answer, and when we just leave the room from the rounds, we might get some answer a little bit later. But the dementia is quite difficult because there are a lot of other dementias what patients can have. It can be there are some important differential diagnoses, but the problem is that there are very often not differential diagnoses, that there are comorbidities. And this comorbidities makes it so very difficult to differentiate what is what. Imaging, while we need, of course, the ventricles, we need the size of the ventricles, but also we want to have more detailed signs, like you can see it here, the dash sign. So you have a large subarachnoid spaces at the bases up to the sylvian fissures, but in the high convexity, it's tight. And in the parafalcine area, you have very small convexities. We call this, I've learned this from the Japanese colleagues as disproportionate and large subarachnoid space hydrocephalus, or DASH. Also the corpus callosum angle, which should be smaller than 90 degrees. An NPH, it's an important sign. We should look at it. But we have to know that not all patients with NPH have a typical imaging. About 80% of our patients with normal pressure hydrocephalus will have this DASH, but 20% will not have a DASH. And this is a problem what we face quite often. If a patient do not have a DASH, they are sent with a diagnosis from the radiologist, oh, no DASH, this is atrophy, no normal pressure hydrocephalus, and they won't be presented at the neurosurgeon or neurologist afterwards. Well, if we think the patient will have a normal pressure hydrocephalus, we should confirm it. And the most popular test is the spinal tap test. And you can see it here, very nice, before spinal tap test. And then after the spinal tap test, you can see how fast the patient, several hours after the spinal tap test, is turning around. So this is quite very nice. And if you see it, if the spinal tap test shows temporary improvement, it's a very good indication for shunting. There is a general consensus about it. But if the spinal tap test does not show an improvement, it does not rule out a normal pressure hydrocephalus, and that means you should do more testing. There was a European NPH study. They could show this very nicely, that the spinal tap test and also the infusion test with the determination of the outlet resistance of CSF can be used very well for selecting patients, but not for excluding patients from the treatment. And why is it so important? I will show it a little bit later to you. What is the problem with the spinal tap test? Well, if you see, you will see now the result of different patients after spinal tap test. You will see here the clinical improvement and here the time. And you see some patients, they just improve very quick, but also deteriorate very quick. You see the behavior of the improvement is very, on the timeline is very different. You see every color is a different patient. And you see now, if you do an examination after 3 or 6 hours, for instance, if you do an examination only once, you will just miss a lot of patients with an improvement. And so you should do a lot of examinations after after the spinal tap test. And what you also can see here, this pink patient, for instance, this patient had a good improvement. He told us there was a good improvement, but the improvement was only subjective. We just couldn't prove this or couldn't show it in our objective tests. And so we just have to look at, we have to do our evaluation a little bit more sophisticated of our spinal tap test. And what we do, for instance, we have observation sheet for our patient, and the patients, they have to log in every hour the first day, how they improve, or at least how is a subjective improvement or not improvement after spinal tap test, and then they have to log in this for a whole week. And if we just look, you see here those original sheets. That is there's a large variety of the timeline, and when they improve, they may improve immediately for a very short time, or they may improve for a whole week or even longer. So there's a very large variety, and the evaluating of symptoms only once or twice means that you will miss a lot of patients with normal pressure hydrocephalus. Well, if you are almost sure that they have a normal pressure hydrocephalus because of the progressive disease, you should treat them. And what we do is, and most of the times that we do a shunt, we do mostly ventricular peritoneal shunt. And in some cases, you might be able to do an ETV, but we have to admit a normal pressure hydrocephalus, ETV has no role. But you will find some subclasses of which present like a normal pressure hydrocephalus. And this is in our department about 10% of the patients that they might have some obstruction, like the infino, like the intratentorial intracisternal obstruction. They might benefit from an ETV, but normally you should not do an ETV in NPH. Of course, we can do it to the peritoneum, we can do it to the right atrium, and what is especially in Japan and Asia very common that you do lumbar peritoneal shunt. This has the advantage that you don't have to puncture the brain, which in my opinion is a very, very large opinion. But all shunts are a very large advantage. Well, all shunts are very successful in NPH treatment, but we have a lot of valves. It's very difficult to know what is the best valve, and also the literature cannot show us that there is really a shunt better than the other. There's no clear evidence that the outcome depends on a special valve, but we must say that adjustable valves show advantages, especially in elderly patients. We just saw at the from the British, the UK shunt registry, that especially in elderly patients, the adjustable valves have much lower revision rates. And what we also know is that gravitational valves reduce over drainage from 30 to 3%. And this was published several years ago. And this was a prospective randomized study. So this is class 1 evidence for NPH. How is the outcome of shunting? The outcome depends, of course, of patient selection. If you have a very strong indication, if you only do after spinal tap test with 20% of symptoms improvement, you may have good results, but you miss a lot of patients. Also, the duration of the disease is very important, because we know if somebody has a normal pressure hydrocephalus for several years, the outcome will be worse than if it's only for 1 or 2 years. And also the length of follow-up, this is very important. We will have good results at the beginning, but if we look at patients after 5, 6, 10 years, we will have a deterioration. And this is because the treatment with a shunt is not a causative treatment. We do not treat the cause. We just do a symptomatic treatment, and the vascular disease, at least the vascular disease, is progressing, and that's the reason why they deteriorate with time. I just will come back to this. If we look to the outcome after 1 to 2 years, it's about 70 to 90%. After 5 to 6 years, it's still good, but it's not as good as we would like to have it. But what we do know, if we have those patients, if we do lower the opening pressure of the valves, at least in a large percentage of those patients, we can get them to a further improvement. And this is also one very strong argument why you should follow up your patient with normal pressure hydrocephalus lifelong. In my department, for instance, it's after surgery, 6 weeks after surgery, and then every 2nd year, or if there's any deterioration. And there's also one very important thing, that we don't exactly know what is the best setting of the valve. And that is the reason why we just do after surgery, if we are not 100% satisfied with the outcome, that we do a titration very often over weeks just to get the best outcome for the patient. Well, what is the effect of shunting? You can see here, if we do shunt them, we just can bring them up almost to normal aging. And this was shown very nicely by Jarai. He could, also with the mortality rate, he could show here patients with normal pressure hydrocephalus over 70 years. If they are treated with a shunt, they have a survival rate of 90%. If they are not treated, 5 years survival rate is only 10%. Of course, after 10 years and 15 years, not so good, because they are elderly patients, they will die someone. But this is, I think, very important. And you just, if you see this, it is harmful not to shunt the patient. And if you tell a patient, it's very complicated operation, maybe some infections or over drainage or whatever can happen, but then you also have to inform the patient about the harmfulness of not operating a normal pressure hydrocephalus. Well, if you want to know everything what is new about hydrocephalus, please join us at the hydrocephalus meeting in this September 2022 in Gothenburg. Everybody of you are welcome. And if you cannot come to Gothenburg, but it would be good to go to Gothenburg and come to Hamburg in 1 year later in 23, and to Japan in 24. Everybody of you are invited. With this, I thank you very much for your attention. Thank you.
Thank you, Uwe. Thank you so much. So now we have some time for discussion and to answer the questions. First of all, let us briefly answer some questions which remained unanswered. The first question for me, why do you think that hydrocephalus has any peculiarities instead of other pathologies which require transition from pediatric neurosurgeon to adult? All other conditions needed? Absolutely agree. All pediatric, the majority of pediatric neurosurgical pathology needs the transitional process into the adulthood. I can tell you that there are special guidelines for the spina bifida transition. They are already elaborated by the Spina Bifida Society, and you can find them on the internet. And oncology, for example, oncology, pediatric oncology, neuro-oncology also needs the transition process, as the chemotherapy or radiotherapy in cases of recurrences may be needed in the adult life. So, and we have very different protocols in the for the children and adults, and this is a big problem for my mind. So some other questions concerning the last two reports. Do you expect changes in the ventricle size in post-shunted adults with chronic hydrocephalus? So Lawrence, Uwe, who can answer this question?
Usually not is the answer. It's usually not discernible and not a very good clinical guide. In fact, at a research level, if you do volumetric scans, you can show a decrease in ventricular size even in a lot of adult patients. But it's not the same as in the pediatric group where it's a good guide to their condition. Sometimes the ventricles change hardly at all after shunting, and yet the patient is clinically much better.
There's also important, I think that we, in an adult, we use, at least we use only almost gravitational valves. And we know that in gravitational valves, also in children, the change of the ventricle size is minimal or often minimal. But we do see that there's a little change very closely to the change what we also see in ETVs. In ETVs, in endoscopic third ventriculostomies, we also see only very slight change of the ventricular size. And if we do have in adult a massive change of the ventricular size, or even if they close to collapse, it is very sure that this will be an overdrainage.
Mm-hmm. Thank you. I think the next question may be addressed to Henry. And I think this is the question from an adult neurosurgeon because the pediatric ones know the answer. So do ventricles in future may be benefited by lavage and shunting may not be necessary in selected cases? Please comment.
You mean in adult patients?
No. I think in all in our patients, perhaps. So I am a pediatric neurosurgeon. I know the answer for the neonates, but perhaps you can comment on other age groups.
Yeah, so lavage we do when we have infections. This can also be done in adult patients, of course, when you have a ventriculitis. What is rare? Usually it's shunt related, but if you have it, we try to remove the catheter and then we rinse the system. And we had also some patients, they had a ventriculitis after shunting because of aqueductal stenosis. So we removed the system and then we make an ETV. And this was working well because the subarachnoid space was not infected. It was completely clear. When you look down to the ventriculostomy, you saw basilar artery and no membranes. So this is an option. And sometimes we did it when there was intraventricular hemorrhage to remove the blood, but we stopped this because it takes too much time. And nowadays we just gave RTPA to make a fibrinolysis and put an extraventricular drain. But the indication for that is rare to make lavage in adult patients in our experience.
Henry, I know that Ulrich has an experience in the treatment of ventriculitis by the lavage in the young children, but you know somebody in the IFNE who use this method in adults.
Yeah, if you have a ventriculitis, as I said, I think it can be done. And I think, I don't know who is doing it, but I think it makes sense to remove all this infected material. Mm-hmm. But in hemorrhages, when we have an adult patient with an intraventricular hemorrhage, usually we place a drain, EVD, and we make a lysis of the clot with RTPA. Mm-hmm. Which should not be done in the infants, right, Mansoor? You said it's not a good idea, then it starts to bleed.
Sorry, I think absolutely I agree with Henry. I'm not aware of it as at all being clearly beneficial. It's going to change the on-call system quite heavily if it did. But yeah, it's an interesting question. A quick comment is that regarding the ventricular size change, and by the way, brilliant presentations from Lawrence and Uwe. And every time I listen to Lawrence and Uwe speak, even though I think I may have heard them speak before, I'm learning new things. Regarding the ventricular size in NPH, I think it would probably be a mistake to chase that. The vast majority don't even need any change in ventricular size to improve. And I think you could easily run the risk of over drainage and getting a subdural if you look for that. So it's just I think a comment. But really,
the ventricular size in adults may also change significantly. If you have a chronic hydrocephalus, of course, the change is not much. And as Lawrence said, there are some investigations to make a 3D measurement of the volume, and then you see there is a slight decrease. But we have also acute cases of hydrocephalus, and then even in adult patients, the ventricular size is changing tremendously, also after ETV.
Ulrich has a thing that he always says at this point in time, which is that what we're really treating is the brain and not the ventricular size. And even with a modest change in ventricular size, you can have a significant change in brain volume, because the brain volume is on the perimeter of the ventricles. So even with slighter changes, you get a pressure you get rid of the pressure decompensation on the brain, and you actually do acquire more brain volume. So I think, that this might explain why we sometimes do not see a significant change, or what we think is not a significant change in ventricular volume, but we still see a marked clinical improvement.
Yes, of course. The clinical improvement is the main marker to determine it's a success or not. That is no question.
Okay, thank you. And now we have to answer the most important question in the treatment of hydrocephalus: how to choose the proper shunt settings. Who can, any ideas? Who can answer this question? Let us ask everybody of our faculty. So what is your opinion?
So the first method is to avoid the shunt. If we have an occlusion of the hydrocephalus, then we should take some endoscopic action, septostomy, ETV, anything. That is the first and the most important part for me.
Of course, the president of IFENI couldn't answer in a different way. Okay.
He is not the only one in complete agreement with this. And even, if you have a patient who has a history of shunting and who has been through a number of revisions where it sometimes becomes obscured by this history that ETV could actually be an option, if you can free this patient from this difficult shunt history, is one of the great successes. That being said, I think that in choosing the setting of a shunt, I think you must be aware of two things. One is that there is a difference in the posture of the patient. So ICP is different whether you lie down and you stand up. And this is the reason for the recommendation of anti-gravity devices or other anti-siphoning devices. You must be aware that the upright pressure is slightly negative, and that is not abnormal. The other thing is that assuming that the goal of our treatment is to reach ICP as close to normal values as possible, I think we have to know what the age-dependent normal values are. There are very, very few publications about this, but one is from Professor Watkins' group, actually, with Kari et al. As the primary, as the main author, published in ACTA a few years back, and one from my own group. And these have actually almost identical graphs of the age-dependent ICP during day and night, or during upright and supine positions. So you can use these figures as a guidance for your shunt setting. And if you have any difficulties at all, I can only recommend to guide it by ICP monitoring in parallel, either by implanting a cabled monitor and adjusting the pressure as you can, to optimize ICP values, or by putting a telemetric device into the shunt system, which will make it possible to monitor ICP values along the way. So that was my answer.
Well, if I may answer for the elderly people, especially for the patient with normal pressure hydrocephalus, first of all, the same as what Marianne said, we have to look for or something against overdrainage. So we need anti-siphon devices or gravitational valves. This is a must today. But there are so many things we don't know about normal pressure hydrocephalus, and we have to be aware if we do shunt a patient, we never know exactly the shunt setting, what we need and what the special patient really need. That means if you're not really very, very satisfied with the outcome, we just have to titrate the symptoms as long as we are in the optimal setting. Of course, we know very much what is the most common setting, but in the special individual patient, we don't know it exactly, and we just have to try it. It's fatal from my point of view if we just put a shunt with a special setting in there and there's no real improvement and we just say it's a non-responder. This is a real mistake. We just have to look in every individual patient. Of course, this needs a lot of stuff. It's unfortunately, it's not reimbursed very well. And this is also a problem for the patient that they don't get enough doctors who could do this and would do this.
Mm-hmm. Who else can contribute to this question?
There are general guidelines of starting points, which I don't think is what we're talking about here. Like in older patients, you tend to start off with a lower part, a lower fixed pressure on their adjustable valve than in a younger patient got perhaps intracranial hypertension, in which case you don't want to overdrain them and collapse their ventricles. So we know that it's sort of roughly in NPH type people, it's usually around 5 centimeters of water. In a younger person, it's going to be more like 10 centimeters of water. And the gravitational component depends on the height of the patient and, if possible, some estimation of their intra-abdominal pressure, because that has to be taken into account as well. And so adjustable valves are valuable for this. And then you have to decide on what you want to optimize. So if you've got a good clinical parameter, you can optimize it by measuring their 10-meter walk or their particular cognitive performance if you have neuropsychology services. And so not always are you trying to optimize to a particular ICP, although that's a good guide. And this will depend on the individual. What are you trying to optimize and what can you measure? And then you can home in on what gives the patient the best result. And I think the more that we understand and can measure outcomes, the more scientific we're going to become on exactly what our shunts are doing in these patients and what the setting should be. So, as Marianne mentioned, the implantable ICP monitors, either as part of a shunt system or separately. And what we heard earlier on about ultrasound, these things are non-invasive and can be repeated. And so non-invasive measures of what the shunt is doing matched against clinical outcomes, I think that's the key to deciding on what the correct setting of the shunt is. There's not one size fits all.
Okay, thank you, Lawrence. So, dear friends, we are working more than 2 hours and a half. So if somebody wants to comment any aspect of our discussion, you are welcome. So
there was one question just came in about the effectiveness of ETV in normal pressure hydrocephalus. I think that is important that we address it. Uwe has already said that he thinks it has no place, and that is my feeling as well. So we just made a study and compared it prospectively, but we have not the final results yet. But my impression is that ETV is not working well. And there is an Italian study from many years ago, and they showed they had a 70% success rate in the long term with ETV and less complications than with shunt, and they recommended this. But when you look at the data, I think it's not clear that it's really an NPH, or that was some cases of aqueductal stenosis included, or what Uwe mentioned, the intracisternal occlusive hydrocephalus. But in general, ETV and normal pressure hydrocephalus, if you have really a normal pressure hydrocephalus with no obstructions anywhere, I think it's not working, is my opinion. Uwe?
There was also a prospective study from Pinto from Brazil, and he could show that that the shunt is much better than the ETV. What you can see if you do ETV and normal pressure hydrocephalus, you will get some amount of improvement. And this probably was also the case in the Ganjemi study, that you get some improvement, but not the improvement what you should get treating this normal pressure hydrocephalus. And this is important. This is the same, as I said, also if you don't have the right setting of your shunt, that you can titrate it. And there was another study or started a study from Richard Edwards, but he had to close the study because of the bad results of ETVs and normal pressure hydrocephalus, and could also show there, but he had to stop it because of the bad results of ETV, and he showed that the shunts were much better. So for me, it's also with the literature already now, there is no place for ETV and normal pressure hydrocephalus, but we have to be aware that normal pressure hydrocephalus, there are several times some different entities are under the clinical signs of normal pressure hydrocephalus, as Henry just said, and we just have to look very carefully at the MRIs, and we may see some chronic obstructive hydrocephalus, what kind of ever, and we should look at those. There we can do an ETV, but at the normal NPH, no ETV.
I think that is very important statement, Uwe, that the triad with dementia, gait disturbances, and incontinence is a sign of chronic hydrocephalus. It has not to be a normal pressure hydrocephalus. I have seen several patients with aqueductal stenosis in the older age, and then you make just an ETV, and they will improve as well. It's just a sign of chronic hydrocephalus. That is a very important statement.
These were your arrested hydrocephalus cases.
Yeah, exactly.
As I was mentioning in my talk on the adult hydrocephalus, the presentation can depend on the age. So even if you have LOVA with aqueduct stenosis, they can still look like normal pressure hydrocephalus clinically.
Exactly.
Sergey, a quick point to make is this, and again, I'm listening and learning a lot from the masters. Imagine if we were trying to do an app to decide who needs a shunt and what kind of shunt. This is perhaps a question to put all this into garment, into what's come up. And I do a little bit of work with artificial intelligence, and I'm no expert in it, but it's attractive idea to be able to put the figures in and the facts, and especially Marianne's classification of aspect, and come up with this. And as Henry made a brilliant point, which is very penetrating, about there's no such thing as arrested hydrocephalus. It's not about the terminologies we use. It's about understanding what is the pathology and who the patient is and what you're dealing with. And my personal feeling is that, yes, you can eventually come up with a good algorithm to give you a guidance, but you can never say to anybody, you should use this shunt or that shunt, etc. It's more about understanding the principles. And some of the points too that's sort of been gleaned from the other presentations and webinars, and this one, is that you need to look at your patient. You need to look at your resources, and you need to know, sort of be more aware of your expertise and your unit. For example, it's interesting to note that I was told in Colombia, majority of shunts are ventricular atrial shunts. I think Lawrence was in the meeting when we were told that. And we certainly know the majority of shunts which are put in for normal pressure hydrocephalus in Japan are lumbar peritoneal shunts. And it's not just cultural difference. There's a variety of reasons that has evolved. So I think it's very important to know that there is no such thing as that shunt is the answer. There's more than 170 of them, I understand, on the market. It's more about understanding the principles of what you're trying to achieve with that shunt. And increasingly, I'm going more and more towards a shunt, particularly for the elderly, more older population, that will give you optimum control and has an anti-gravitational device and can give you the best control with setting the pressures, as well as anti-gravitational, as well as being, MRI safe. And I come back more and more towards Marianne's paper about aspect and inculcating that in mind when making those decisions, looking at the anatomy, looking at the symptomatology, aspect, looking at previous intervention, and looking at, in your mind, what is the etiology, what you're trying to treat here, and what's been the impact of various etiologies on that patient. And also, what complications have they had? And what time and period they are in their hydrocephalus. And I think these have been very key ingredients in order to decide what shunt do you use.
Thank you for that comment, Mansoor. And I think, the timing aspect becomes particularly important when you are dealing with a pediatric hydrocephalus, because the physiology and the size of the body is undergoing a lot of changes. So the best advice in that situation is to accommodate this by choosing a shunt which is modifiable during the child's growth. Of course, we all know that there is a risk of revisions, and these adjustable systems are more expensive than fixed systems. But if you are in that situation that you don't think you can afford a fully adjustable system, well, at least you could put in the an anti-gravity or over drainage protection, and then at the next point in time when the child needs a revision, you could reconsider the need for an adjustable or even a double adjustable valve.
Absolutely, and I've just was reminded with that Lawrence, I think, touched on a very crucial point, and something I had not looked at before well with his slides, which is something we know, but the heart is beating and you've got a solid structure. And we have to appreciate more and more, hydrocephalus management is not about releasing compartments. It's about, in terms of pathology, more to do with what happens to that waveform with your treatment and in which compartment. I think the evidence for that is becoming more and more clear. What happens to the dynamics of the brain and the CSF pressure before and after treatment? And I think that will be a greater revelations in the future with the telemetric devices and what we will glean from the waveforms.
Thank you. So I think that despite the surgery for the treatment of hydrocephalus perhaps looks not so complicated, it looks rather easy, the shunting procedures and even the endoscopy, but the pathophysiology of this process, the decision making is very complicated, and we are far from understanding all these processes. And I address perhaps to the young neurosurgeons who are listening us. So here is a very wide field for the investigations and for your efforts. Okay, so dear colleagues, I think that we are coming to the end of our event, and Marianne, please say some words to conclude and to summarize all our discussion.
Well, thank you very much. I completely agree with you that there's still too much that we don't understand. Sometimes we don't know what part of the physiology we are changing or even ruining by putting in a shunt if we bypass some normal regulatory mechanisms, which may increase the risk of over drainage. I completely agree with you. There's so much to be done, and a lot of this is not going to be in the professional lives of several of us. So we can only encourage our young colleagues to take up the task and continue to expand knowledge in this field, because it's greatly needed. It was said at the beginning that hydrocephalus is a very common disease. Hydrocephalus and regulatory management of ICP is still probably the most common neurosurgical procedure, and we need to know more to do that better.
Thank you. And I have the last questions to Lawrence. So I have noticed that you have a very nice logo of your hospital. What does it mean? Usually they draw a brain as a logo of a neurosurgical hospital. Why do you have the flowers on your logo?
You've got to remember that the hospital dates back to the mid-19th century, 1860 in its current form. And it did start off as the only neurosurgical and neurology hospital. It was literally the national hospital for neurosciences within the UK. And so those flowers are the symbols of the 4 nations that make up the United Kingdom. England, Ireland, Scotland and Wales each have a symbol flower. And so that symbol that you noticed is just the unity between the different parts of the United Kingdom.
I may wish all of you to have more patience, not with the hydrocephalus, but with the flowers in their hands. So thank all of you. And I invite all our participants to the Belgrade Congress, which will take place in October, and there will be several master classes and joint sessions organized by the pediatric section of EANS, and I think that there will be much more acute problems which we shall discuss. And have a good luck and have a good evening. Thank you to all of you.
Thank you
Thank you
for
very
your
much.
invitation. Bye bye. Have a nice
Bye-bye.
evening, everybody.
Bye-bye.
Bye bye.
Bye-bye.